I will start by saying that the topical therapies that I've selected are certainly not all the topical therapies, but they're the ones that I hear of most often. I will mention one of the topical therapies I'm going to mention is something in early phase trials that I am an investigator for. So the idea of topical therapy is try to put something on that really can heal blisters more quickly, could decrease the risk of infection or maybe modify mild infections, can decrease itchiness, maybe decrease redness, all of these factors that are so problematic with individuals with EB. Now, one of the problems with topical applications is that we generally use topically applied agents because we don't want to give things by mouth or by injections that get into the systemic bloodstream because there can be more potential side effects with that. So a great concept of topical is that we get it right where we want it to be, and we don't have to worry about having potential side effects from internally, having our internal organs exposed to topical products. But one of the problems with EB that I just want to emphasize is that there may be safety issues that may not occur with other situations where you're putting something on topically, but the skin is intact. And that's because, of course, the skin barrier, just to review with you, is very important as a mechanism for us. And here we have the outer layer, that stratum corneum, which has these tightly woven proteins that keep things out and keep water in. And in between these layers and at their surface are these lipids or fats that really help to do that job. And then even deeper in the epidermis, we've got cells with regions between them that have junctions that also are tight, and they prevent things from coming in as another defense. Now, even in EB simplex, we're talking about changes that affect the cells down here. But whether we're talking about EB simplex or junctional EB further down, or even further down with the dystrophic forms of EB, we still lose that entire protective layer, so that even topical treatments, we have to think about the safety of them. Now, I'm not going to talk, for example, about topical steroids. I'm happy to answer questions about that. I know I was talking last night with a couple whose granddaughter has junctional EB and has all that granulation tissue around, something that we use sometimes very aggressive systemic steroids for. But we do have to keep in mind that that's something that we have concerns about using for long periods of time, particularly over large surface areas where we have these open areas, because there can be that absorption. Now, I also am going to talk a little bit about the concept of trials and why trials are so important. And this is true whether we're talking topical agents, gene therapy, systemic medicines, whatever. Because pretty much everything I'm going to mention today, I went to the literature and I looked, and there's virtually nothing there. And many of the things that are there are case reports where there have been a few people who've tried it and it's gotten written up. There are very, very few what are called double-blind, randomized, controlled trials. And I want to just explain to you a few terms I might use. When I talk about an open label trial, that means that the actual medicine, it could be in an experimental form, but that the actual medicine is being given to everyone. Everyone knows what they're getting, and everybody's getting the active stuff. That's a problem sometimes because we don't know what's called the placebo effect will be, which is just the effect of knowing that you're trying something different. Feeling so much better, for example, because you know you're getting something. Being much more attentive, whether it's to dressing changes or the way that you take care of yourself, because you're in a trial and using something that's active. Now, in a double-blind trial, neither the investigator nor the individual or family knows what he or she's getting. Randomized means that at the institution or centrally using a computer, you getting the medicine could get A, could get B, could get C, but nobody knows, because it's not like it's the first person is A and then the next person is B and then the next person is A and then the next person is B, in which case the investigator will know, well, I gave some yesterday, so this person must be the opposite. No, randomized means it's totally random. so that no one knows what he or she is getting. And then, very importantly, control means that there is a placebo arm with a topical that can be a vehicle, what the base is for the topical. If it's a pill, it can be a sugar pill. If it's an injection, it can be a saline injection. But it is a controlled trial. There is an arm that has basically nothing being given. And that's critical to be able to know what, when you're doing nothing different, the difference is. Now, sometimes clinical trials are not effective and there's problems with designs or there are not enough people in them. Here's an example. Some of you may have participated in a trial that ended a few years ago of a new agent that people thought might really be helpful with EB in healing wounds. It was called thymosin beta-4. It was an 8-week, double-blind, randomized, placebo-controlled trial. There were 3 concentrations of medicine and there was the vehicle base. There were about 25 in the trial, about half children, and it showed it was very safe. But in this trial, there was no evidence that the wounds closed more rapidly in the ones getting the active ingredient versus the placebo control. Now, there were a lot of problems with this study. There were blood levels, a small pool of participants willing to do it, ended up terminating early, so it may not have been powered, which means there maybe weren't enough in this trial to even show an effect, but it didn't even really show a trend. So it was important to do that trial in a double-blind, randomized control manner to make these kind of judgments. Now, I'm going to be talking about topical agents. These have not been in randomized, double-blind controlled studies. In fact, only one of them so far has moved forward to that. But nevertheless, I'm going to tell you about anecdotal evidence, my experience, and what's in the literature. And we're going to talk a little bit about coconut oil, medical-grade honey, topically applied silver, keratin-containing products, and then an SD-101 cream that someday will get another name. So, coconut oil. And let me say too, by the way, any of you listening to this, I would love to hear from you if you have any comments, because I'm always learning. I learn so much from my own patients and from you. So if you have experience with these that you want to tell me about, please feel free to email me that as well. And my email, by the way, is apaller@northwestern.edu. Very simple. So what about coconut oil? So there are lots of those on the shelf. Pretty much you're going to find ones that say virgin coconut oil. So what does that mean? Well, you don't want something that's not virgin coconut oil, because this means that it is made through a process that does not add chemicals, that does not use heat. It is a wet milled, cold press process. And make sure that if you're going to try this, you use virgin coconut oil, because otherwise there's bleach in it that changes the composition. Extra virgin is a marketing tool. There's no difference between extra virgin and virgin. But virgin coconut oil is what you're going to look for. Now, not all oils are alike. So for example, we've got olive oil on the shelf that we use in cooking. Don't put that on. That's different. So 82% in virgin olive oil is unsaturated fatty acids. Well, that's great for cooking, but it's very different in composition from coconut oil, which, for example, is only 8% unsaturated fatty acids, and especially has a lot of what are called medium-chain fatty acids. So they're not all alike, and you'll see that because I'll mention some trials in a minute. Now, this is clear like water. It's not greasy. It spreads easily, so a lot of people like that. But what do we know about coconut oil? Well, there's not a single trial in EB. It'd be nice if we had one, but there's not a single trial in EB. There are 2 studies, though, that I was able to find with eczema. Now, many of you may know eczema, a very, very common problem in which the skin is red and itchy and dry. And in eczema, just like in EB, there can be overgrowth of certain bacteria. So in eczema, one of the bacteria, particularly the one that's there early and then continues throughout life, especially in recessive dystrophic EB, is called Staph aureus. And the vast majority of individuals, if you did a swab, especially in an affected area, you would find Staph aureus in eczema. So this was a study where adults were treated either with the virgin coconut oil or the virgin olive oil twice a day at sites without any evidence of clinical infection, but they still are colonized. They have this Staph aureus if you do a culture on it. And what was found is that with the coconut oil, 77% were cultured originally in an area without clinical infection and found to have this Staph aureus. And with the coconut oil over this period of time, it went down to 5%. Whereas with the olive oil, there really wasn't any change. And using a score that's used for eczema called SCORAD, the virgin coconut oil also showed more improvement in these adults with eczema. Now, why is there an antibacterial activity? Well, we really don't know much about that. It's thought to be something called monolaurin. It's a lauric acid. But even there, going into the literature, there was controversy in studies whether the monolaurin really is even in the virgin coconut oil, if virgin coconut oil even has good antibacterial effects. As you can see, a lot of questions still out there, but it's thought from that study and some others that there are antibacterial effects. There was another study in eczema in kids with mild to moderate eczema, and here they were treated with either virgin coconut oil, here compared to mineral oil. They didn't get any other treatment like steroids or things like that. And using this score that we use for eczema, there was a difference in the improvement after 8 weeks of treatment. Now you see here, I'm just going to show you, if you ever read literature and you're looking for whether something had a significant effect, that word significant has a meaning that it has been rigorously looked at with statistical analysis. And if you see something that has a p, we're generally looking for something that is a p of less than 0.05. This is less than 0.001, which means that it certainly was significant. And there were also significant decreases both in the appearance of the eczema and in the associated itching, as well as an improved ability to hold on to hydration in the skin. And there has been another study in premature infants showing reduced water loss through the skin with coconut oil. So there are some studies out there, nothing in EB, but some reasons to think why it might be helpful for some individuals. One thing that's to beware, and that is that coconut oil is thought to have an ingredient that can cross-react with one of the hot new contact allergens called cocamidopropylbetine, or CAPB. And this has been increasingly recognized as a trigger of what we call contact dermatitis of the allergic type, like poison ivy is another form of that. So we can get these rashes on the skin from it. It's in shampoos, it's in no-tears shampoos and soaps, it's in wipes that we might use, facial wipes, hand wipes, baby wipes, and so it's out there in the environment. And I just mention it because if you're using coconut oil and over time there seems to be some increased inflammation or even a rash, think about that possibility. Now let's move on to medical grade honey. Now, medical grade honey is not the honey you get off the shelf, and I want to stress that. It's really important to recognize this is Manuka honey from a bush that grows in New Zealand and Australia, and it has lots of something called methyl glyoxal, or MGO. Why is it important to get medical grade honey and not just slop on some honey from the store? Because medical grade honey is sterilized. Otherwise, it's contaminated with bacteria, including the possibility of botulism spores. We talked about botulinum toxin and injecting it into the bottom of the feet. There are some neurotoxic effects that are possible if you get botulism spores contaminating. And the medical grade stuff has also been tested for antibacterial activity, so it's not all over the place in what it should do. The antibacterial activity in studies have been thought to result from the fact that these are relatively acidic, they have a low pH, they have a very high sugar content, and that is antibacterial. And then this methyl glyoxal is also thought to play a role, and in studies it's clear that there are some other components, we don't know what they are, that also function. So again, not a single trial of its effectiveness in EB, but this has been shown to have activity against Staph aureus, including MRSA, that methicillin-resistant Staph aureus that we worry about, and we worry about with antibiotic resistance, and also Pseudomonas. So the two bacteria that are a problem. Now again, Don't just buy honey off the shelf. You got to get medical grade honey. And these tend to be available as a gel. That's what we most commonly use. It's not pure honey and can be put on with dressing changes. There is a paste, but it's 100% honey. It can crystallize. It tends to be tackier than the gel. And it's also available in some dressings, but you got to be careful about their stickiness. Sometimes it stings when it applies, so if you're going to try this, try it on a small wound. Don't just suddenly put it all over the body. And realize that if you dilute it, it can decrease the stinging, but it's not as affected if it's diluted by other products, or if there's excessive wound drainage, it also may not be as affected because it's being diluted. Also, it's been shown that when you start to use the medical grade honey, it can increase drainage from wounds. Maybe it's the high sugar content's pulling it out, but that initially will require more frequent changes of dressing. What about silver creams and dressings? Well, they're known to be antibacterial. There are doctors that don't want to use these because of concern about silver. And that concern relates to the fact that if you're chronically exposed, it can lead to the deposition in skin. That's called argyria. And it can give you a permanent kind of ashy gray color to the skin. It can deposit in eyes. It can deposit in your internal organs. Now, that is a potential cosmetic issue. Any kind of silver, when you put it on, could potentially stain the skin as well. Rarely there's an allergy and some other, like a peculiar form of anemia called methemoglobinemia and some other toxicities, but those really are pretty rare. The big problem is this argyria, getting it into the bloodstream, possibly getting it into your skin. But even silver applied topically can enter the bloodstream. It is cleared by the liver and by the kidney, so that if you have liver issues or kidney issues, you want to be particularly careful with it. And I'm showing some forms of silver. In general, I'm worried more about the colloidal silver cream. Some people use silver sulfadiazine. Probably the best way if you're going to use silver is to use it in dressings, because they hold on to the silver. There tends to be less that can be absorbed through the skin as a result of that. Now, one thing to know about silver is that to have an antibacterial effect, it has to be what's called ionized. So silver ionizes in the presence of water or body fluids or tissue drainage. There's no point putting it on a dry wound or dry skin because it's not going to work. It has to be wet in order for it to be effective. And if you use it like we often do, putting a greasy product under a dressing, let's say petroleum or aquaphor, whatever we might be using, then you're not going to get the water in the area coming out from a wound or whatever to the silver. So that's another problem. You've got to be careful about that. So remember, you need to have a wet environment for it to work. As mentioned, there's more release from these silver-containing creams, especially colloidal silver, than from dressings, but there has even been a report of getting argyria from dressings. So that's why some people are concerned about it. I use it, but I limit the exposure to a few weeks, and I'm not using them on large body surface areas. I like silver socks. I just want to mention those while we're talking about silver. We use these a lot with EB simplex, but they can be used with anybody who's having issues on the feet, and sometimes we even put them on the hands. These are not something, oh, what is that? Sorry. Oh no. Hold on. I don't know how to get this to work, so, okay. And anyway, so silver socks are not something that you can just go online easily in the United States and get, but I have several patients who get them because you can email to a company in England. Can we just, oops. Here, that's okay. There we go. Okay, sorry about that. There is a company in England that sells these, and if you want to write down this email address, you can email to them. And they come in adult sizes. They're black. They come in kid size, a whole bunch of kid sizes, pink and navy blue. And the way that we often like to use them is one pair over another. They're not real thick, so you don't get very hot in them, and then that decreases the friction between the feet and the shoes. And it also tends to have an effect in keeping the feet a little bit cooler, so it's something that I do recommend. Now, moving on to the keratin-enriched gel, these are commercially available as a gel and in dressings, and there have been some laboratory studies of wound healing in cultured cells. You can take skin cells or keratinocytes, you can grow them up in culture, you can create a wound healing model in the lab where you take this bed of skin cells and you scratch uniformly, and then you watch them move. And you can do these kinds of studies. And then in the lab, we can watch these skin cells move more quickly when exposed to the keratin-enriched material, and make more proteins. And one of those proteins that there is an increase in production of is collagen 7. So studies in mice and in humans have suggested that wounds, not talking EB wounds, not studies in EB, show faster healing with the keratin dressing. Okay. Now, there haven't been any double-blind, placebo-controlled, randomized trials with this, but there have been a few open-label studies in EB here, and including some that were just shown at our most recent Society for Pediatric Dermatology meeting, and I'm just going to mention results from those. There were, in a recent study of 10 patients, 4 with recessive dystrophic, 3 with junctional, 3 with EB simplex, 2 ended up discontinuing because of itching, but 6 of them found that it helped with healing, including 4 of the recessive dystrophic EB patients. Patients found it easy to use, but it's sticky, and you have to realize it takes about 5 to 10 minutes to dry. It can sting, and so sometimes it's better if diluted with another product, like a topical antimicrobial agent. And then finally, I'm going to just mention SD101 cream. I know Dr. Ryan gave you a talk earlier in the meeting about this project. This is an agent that's currently in trials right now, but I had the privilege of participating in an open-label, single-site study at our center, and I just wanted to show you some of that. That was with a 3% SD101 cream, in which we looked at 8 patients, average age 3 years, with a variety of different types of EB, just for the first time to get an idea whether this might be something worth pursuing in the real type of study, not open label, but the double-blind, randomized control type of study. Now, 3 of these patients had surface area involvement that was 26 to 50%, 5 had more than 50%. So these were pretty affected kids. And the target site that we were studying had to be something chronic, that is, it had to be there at least 3 weeks or more, with endpoints on the size of the target lesion and body surface, with endpoint actually was closure, as well as the body surface area that was involved. It was tolerated very well. The target lesion averaged in size about almost 4 square inches, and 7 out of the 8 closed within the month after starting treatment, and the effect of body surface area reduced progressively as well. And I just created a little graph to show that going down over the 3-month period. So that was very encouraging. A few examples. Here was a kid with EB simplex, a 4-year-old who had 67% body surface area with some blisters, erosion. The target lesion closed within a month. The body surface area decreased by 73% at 2 months and 83% by the 3 months. And one of the things that was really interesting in this patient is that there was marked thickening noticed, for example, over the elbows and knees. And at the end of the study, it was dramatically less. And this actually shows it just at 1 month. There was a 1-month-old who had about 50% body surface area involved. Target lesion closed within a month, and the body surface area similarly decreased progressively. By 2 months, went up a little bit of a bump as often occurs in these studies, but still pretty dramatic by the end of that treatment. And here's an example of a patient with recessive dystrophic EB, a 3-year-old who had 32% of the body surface involved with blisters and a fairly large target lesion that closed within a month, and almost a 50% decrease in body surface area affected by wounds by 3 months of age. So that was very encouraging, and that has led to the study that you heard about, the first double-blind randomized vehicle control multi-center trial, and this compared vehicle with 2 different concentrations, 3% and 6%, applied once daily for a 3-month period, and that was in just short of 50 kids who started that with the primary endpoint, closure in a month, and some secondary endpoints that we were very interested in, not just the body surface area coverage over the 3-month period, but very importantly, whether there was a change in the quality of life, a change in the itching, a change in the pain, early on and then throughout the study. And we have an open label pilot study now of that target 6% that is ongoing. And of course, we don't have data on that yet, but stay tuned. We're very excited about the idea of actually moving forward with these types of double-blind randomized controlled study. So in summary, several topical agents are available. They largely function to promote wound healing, including through their antibacterial properties, because bacterial infection slows wound healing. Our use should be selective. For example, when using an antimicrobial dressing, you want to discontinue it when improved. The reports are largely anecdotal, and most are not studied in double-blind, randomized, vehicle-controlled clinical trials, and that needs to happen. But finally, before I close, I just want to mention one thing. And this comes up and is very timely, because in the Wall Street Journal on Wednesday, just this past week, I don't know how many of you were read that journal and saw that, but there was a front page article about these double-blind studies and how social media may be compromising them. And this is something I think we all have to think about seriously. We use social media a tremendous amount in the EB world. We all know that. It's a wonderful source of information. It's how we share information. It's how we reach out and have a network of other affected families. But we have to be careful that we don't jeopardize these types of trials through what we say on social media. The article in the Wall Street Journal was about multiple sclerosis and an important trial that a woman was involved in. And it was a trial where previously there had been a type of shot that was used, and she had actually been on it, been using that shot. And in this new trial, they were testing something that was actually an oral medicine, a pill that could be taken, so much better, but they had to compare it against something, so they compared it against the shot. And when you do that, you have a sugar pill when the shot is the active one, and you have some saltwater shot when the injection is the active one. And this woman blogged, and she blogged about how she figured out which was what. She figured out from the way the shot felt that it wasn't the active one she was getting, and then she put two and two together and said, I must be getting the active pill. So she spread this all over, as well as every single detail about being in the study. And others sometimes do that as well. And the problem is that when that type of thing happens, it can totally ruin a study, because you lose the double-blind nature. The patient may figure out what's going on. It may get back to the doctor. It changes what makes this type of study so successful in our figuring out if something is going to work before it's released and goes on the market. And so I would just say that even though we think everyone should be continuing to talk and chatter about things, that you need to take this very seriously. What happened to this woman in the article is that over time she started becoming a speaker, and she started understanding that she could have jeopardized that entire trial by getting out there and saying things that could be influencing other people in the trials. So as we move forward in this new world of EB, whether we're talking about topical therapies or injected therapies, systemic therapies, gene therapies, those of you who are part of trials need to be very careful in the type of information that you get out in a public network like that, because we want the results of these trials to be accurate, and that's the best thing for affected individuals with EB. And with that, I want to thank you for your attention.